Hello and welcome to Sureena Speaks, and today we're going over chapter 9 of the BNF, which is blood and nutrition. So with this particular chapter, what's included in it is different types of anemia, blood and electrolytes, vitamins, and with the vitamin section in particular, we'll go through that towards the end of the video, and we'll go through all the different types of vitamins there are, so A, B, C, D, E, which products they can be found in, so cheese, meat, milk, etc., and what effect a lack of that particular vitamin can have on a person. Now that side of stuff is actually quite nice to go over because it's to do with food, so I actually quite like that particular section. But let's start off with anemias. So there's many different types of anemias and there's many different treatment options for those different types. So we have, for example, iron deficiency anemia, sickle cell anemia, megaloblastic anemia, but let's start off with sickle cell anemia. So patients that have sickle cell anemia might need folate supplements, and they might be on a medication called hydroxycarbamide. And what this does is it reduces the frequency of a patient getting sickle cell crisis. And if they get sickle cell crisis, usually that leads to hospitalisation. So that's why they would be on hydroxycarbamide. We also have G6PD deficiency anemia. So with that one, it's usually more common in men than in women, and it's usually mostly seen in Asian, African and South European patients. And what's important to know about G6PD deficiency is that when drugs are tested routinely, a lot of the time they aren't tested in patients that have G6PD deficiency. So just because a medication is safe in one patient with this deficiency doesn't necessarily mean it'd be safe in another patient. But there are some drugs that we know that can cause a risk of hemolysis, so rupture of red blood cells, in patients with G6PD deficiency. So those include, for example, quinolones like ciprofloxacin, nitrofurantoin, and sulfonamides such as clotrimazole. And there are some drugs which have a higher risk in patients with G6PD deficiency. For example, aspirin, quinine is another one, sulfonylureas. They all have some risk. Those drugs have some risk in patients with G6PD deficiency. So we also have hypoplastic, haemolytic, and aplastic anemias. So with hypoplastic and haemolytic anemias, that can be treated with anabolic steroids, various corticosteroids, and pyridoxine. Whereas with aplastic anemia, that can be treated with anti-lymphocyte immunoglobulins. And that's usually given IV through the central line. And it's usually given for 12 to 18 hours each day for 5 days. However, it can cause severe reactions within the first 2 days, and profound immunosuppression can occur as well. But the rate response may increase if something like cyclosporin is given as well. And you also get anemia associated with erythropoetic deficiency, which can be seen in patients with chronic kidney failure. Now, the treatment option for this is very easy to remember because it's erythropoetin deficiency, and the treatment option is Epoetin. Nice and easy to remember, why can't they all be like that? But you can also get something called Epoetin beta, and this is used in neonates with a low birth weight, but you want to use non-benzyl alcohol versions because they're a neonate. You don't particularly want to be giving them alcohol versions. And you also get darbepoetin alpha, and darbepoetin alpha has a long half-life, therefore you don't need to administer it as frequently. So in community pharmacy in particular, one of the main anemias that you may have come across is iron deficiency anemia. It is quite common, and if a patient does present with iron deficiency anemia, it's important that they don't have any underlying conditions, for example, GI cancer or gastric erosion. Now, some patients may need prophylaxis with iron, for example, those that have menorrhagia, preterm neonates with low birth weights may also need, as well as pregnant people, and particularly pregnant people will be given iron with folic acid or iron and folic acid together, especially those that are at higher risk of getting iron or folic acid deficiency. Now we know we can get all versions, you can get modified release versions, But therapeutically, the modified release versions, there isn't really a benefit except that you can take it once a day. Now, you can also get parenteral versions in the form of iron dextrose, iron sucrose, and they're usually given to people where the oral versions have been ineffective, or for whatever reason they can't take the oral versions. If, for example, they have malabsorption. And the main side effect associated with the parenteral versions is hypersensitivity reactions. So, for example, anaphylaxis, and those that are asthmatic or have eczema are at higher risk of this. Now, in terms of general side effects with iron, they include, for example, constipation. Although patients with irritable bowel disease on a modified release preparation can actually get diarrhea. Black stools, that's another key side effect with iron. And patients should be advised to take it on an empty stomach because it absorbs better that way. But if they are getting or they can't tolerate the side effects, it is fine with them to take it after food. And another key counselling point is that whenever you're giving out iron, whether it's over the counter or on prescription, advise the patient to take it actually with orange juice rather than with water because it absorbs better with vitamin C. Fun fact for the day. So another type of anemia that you might see commonly in community pharmacy is megaloblastic anemia, and that's usually due to a lack of vitamin B12, also known as cyanocobalamin, or folate. And you need to establish what the underlying cause is. So a patient might have something called pernicious anemia, and that's because of that, it's causing a malabsorption of vitamin B12. And vitamin B12 might need to be given prophylactically in patients that are undergoing either a total gastrectomy or a total ileal resection. Now, when cyanocobalamin is being given, and it's for vitamin B12 deficiency, then it needs to be endorsed on the prescription SLS. That needs to be endorsed on there. Hydroxycobalamin, though, has replaced cyanocobalamin for vitamin B12 deficiency because it can be retained in the body longer. Therefore, maintenance treatment is usually up to 3 months then, usually by intramuscular injection. Now going on to folate deficiency, so that could be due to pregnancy, poor nutrition, or even some anti-epileptic medication. And a patient would then be on folic acid treatment for usually around 4 months. Now, folic acid, we also know, can be used in methotrexate therapy. So if methotrexate is being used in psoriasis, rheumatoid arthritis, you usually always give folic acid as well because methotrexate is a folate antagonist. So to overcome that, you need to give folic acid. There's also something called folinic acid, but that's usually associated with cytotoxic therapy. So now we've spoken about patients having a lack of iron, but they can also have the opposite. They can have too much iron, they can have iron overload. So that could be, for example, patients that have repeated blood transfusions. So what do we do? So the treatment for this would be a repeated venesection. So essentially taking blood out, but that's contraindicated, removal of blood even. But if that's contraindicated, then an iron chelating compound can be used instead. And administration can be enhanced by using ascorbic acid. And ascorbic acid would be given orally, but it should be given separately from food. And it should be avoided in patients with cardiac dysfunction. So moving on to fluid and electrolytes, we need to think about in what situations would we need to give someone fluid and electrolytes. So for example, in vomiting, diarrhea, particularly oral sodium and water would be given in these states. And so we know that if someone comes in and they have persistent diarrhea, we might recommend Diaurolite to them, which is essentially, it's electrolyte therapy, it's oral rehydration therapy. And we know the benefits of that is that you can give it to children, it's palatable. So that's just one example of when we would give oral sodium and water. What's really key about this particular section though, is that we'll go over the different hyper and hypo states, for example, hyperkalemia, hypokalemia, hypercalcemia, hypocalcemia, etc. The different treatment options, I'll write a list of them. With the hypo states in particular, they're really easy to remember because it's very logical. If you're lacking something, you need that in your system. So if you're lacking calcium, for example, you have hypocalcemia, you need calcium to go into your system. if you have hypokalemia, so you lack potassium, you need potassium into your system. So the hypo states, the treatment options for them, they're really easy to remember in that sense. It's the hyper states that we might need to remember, learn, and think a little bit more about. So, for example, in the case of hyperkalemia, a treatment option actually is salbutamol. Now, you might think, what's salbutamol got to do with hyperkalemia? But if we look back and remember, salbutamol, a side effect of it, is hypokalemia. So actually, in this example, we can use a drug side effect to our advantage. So it's not necessarily the first treatment option, but it is definitely a treatment option. So if someone has hyperkalemia, they have too much potassium, we want to give them something that we know will lower that potassium down, such as salbutamol. So in what cases would a patient be taking oral potassium? So it might be that they're on digoxin therapy, on antiarrhythmics, they might have a lot of potassium floating about in their system, or they might have chronic diarrhea, they might be using laxatives, so again that could be imbalancing their potassium levels. So in the case of hyperkalemia, there's a lot of different treatment options we can give. With hypokalemia, very simply, if you're lacking potassium, you need to give potassium, so you might give it in the form of potassium chloride or potassium bicarbonate. And it's also really important to remember at which drug levels are considered hypo and hyper. So hyperkalemia is above 6.5 millimoles per litre. Hypokalemia is below 3.5 millimoles per litre. So remember those ranges as well, because they like to throw that in exams. So now let's think about why we would need to give someone sodium bicarbonate, for example. So usually sodium bicarbonate is given to patients in a chronic acidotic state. So they might have metabolic acidosis, renal tubular acidosis, dyspepsia, or you might want to be increasing the pH of their urine, for example. So moving on to calcium. So when are you going to give calcium supplements to a patient? Well, in children, in pregnancy, in osteoporosis, and if they're lacking calcium, if they have hypocalcemia, we usually give calcium and vitamin D together in the form of calcium carbonate or calcium chloride. But now what happens if we give them too much calcium? Well, we have different treatment options available, but also we need to restrict their calcium intake. So dietary-wise, we need to reduce them consuming calcium. And also we need to look at what other medication they could be on. And if it's medication that promotes hypercalcemia, we need to reduce that or take them off it or see if there's an alternative. So for example, thiazides have this effect and vitamin D. And in the case of hyperparathyroidism, there are drug options we can give, or they might resort to a parathyroidectomy, so actually removing the parathyroid glands. Talking about magnesium now, so magnesium is used to generate energy and it's excreted by the kidneys. Now a patient might develop hypomagnesia, for example, if in case of diarrhea or even alcoholism. And hypomagnesia can then cause secondary hypocalcemia and hypokalemia. So if we're lacking in something, we then need to give it. So if we're lacking magnesium, we're going to be giving the patient magnesium. Usually in the case of hypomagnesia, it's given as a magnesium sulfate injection. And magnesium sulfate actually is available to the public in the form of Epsom salts, which people believe when they put in the bath, it can help with muscle tension and muscle pain. So now talking about phosphate imbalance. So situations when we might give phosphate supplements are, for example, in patients that have severe diabetic ketoacidosis, those with alcohol dependency, and those that might have conditions such as rickets, where we might give vitamin D as well. So in patients that have hyperphosphatemia, so they've got too much phosphate in the system, we'd want to give them a calcium-containing preparation because this acts as an effective phosphate binder. And something like sevelamer might be given as a treatment of hyperphosphatemia with hemodialysis. So moving on to metabolic disorders, there's a condition called acute porphyria. It's a hereditary condition and some medication are unsafe in these patients that have acute porphyria. They include antihistamines, anabolic steroids, contraceptives, and HRT. Then we have trace element deficiency, which is a really small little section. Examples include selenium and zinc. And again, if we're lacking something, we need to give it. So in the case of selenium, why might a patient be lacking selenium? Well, if they have an inadequate diet, so we're going to give them selenium supplements. In the case of zinc, a loss of zinc could be due to trauma or burns, so we'd give them zinc sulfate. So in terms of nutrition, we might give someone IV infusion in addition to tube feeding. So reasons why they might be on tube feeding is, for example, they have renal or liver dysfunction or renal liver disease. They are severely ill, so they might have just undergone major surgery or chemotherapy, radiotherapy, or they could be in a coma. So we might need to give them parenteral feeding, which is a mix of amino acids, glucose, fats, vitamins. But there are some complications with parenteral nutrition, and they include gallstones, gallbladder sludging, and cholestasis. There's also enteral nutrition, and patients who are severely ill, they have a lack or their body reserves of protein are reduced in patients that are severely ill. So, for example, those that have undergone trauma or burns victims. So with these patients, we would need to give them frequent small amounts of food, and we would need to give them supplementary snacks in between their meals. So in this case, snacking is okay. And why might a person be on enteral feeding? Well, again, they might be in a coma, or they might have some form of esophageal obstruction. There's also something called phenylketonuria. I'm saying that one right, phenylketonuria. And this is a condition when the body can't metabolize phenylalanine. So the way that this would be treated is to restrict dietary intake of phenylalanine, but still give a sufficient small amount so that the body's tissues can be built and repaired. And in terms of nutrition, we need to think about special diets. So some patients might need their diet specially tailored because they can't metabolize certain products. So for example, in the case of celiac disease, patients need a gluten-free diet because they can't tolerate gluten, so they would need then a special diet. So moving on to vitamins, and I quite like this chapter, as I said before, because a lot of it relates to food, so that wins me over. With the vitamin section though, the way that they ask it in exams is usually they'll have options vitamin A, B, C, D, E, and they will describe a condition. So they'll just name that patient comes in with these particular symptoms. They won't necessarily tell you what that condition is though, but based on the symptoms, you then need to work out which vitamin that patient is lacking. So, for example, they might say patient A comes in and they have been getting bleeding of their gums. So you need to think, okay, the symptom is bleeding of their gums. What condition causes bleeding of the gums? Oh, scurvy does. Therefore, if they've got scurvy, that means that they have a lack of vitamin C. So then the answer would be vitamin C. So that's how the best way to learn this chapter, therefore, is to know what each vitamin is, what conditions are associated with it, and in what products you can find them in as well. So are they found in milk? Are they found in cereals? Are they found in bread? And it's important to know which vitamins are your fat-soluble vitamins and which vitamins are your water-soluble. So fat-soluble, remember it through DEAK, fat-soluble are DEAK, and therefore our water-soluble will be our B and C, because those are the ones that we haven't mentioned in DEAK. Easy to remember. So let's start off with vitamin A. Vitamin A, also known as retinol, so think retinol, retina, the eyes. So it helps in night vision, and usually a lack of vitamin A can lead to ocular defects. Lack of vitamin A is quite rare in the UK, but it's still important to know. And in terms of pregnancy, it's the big one to avoid in pregnancy. And where can we find vitamin A? Well, we can find it in foods such as eggs, butter, and fish oils. Now moving on to vitamin B. So there's many different forms of vitamin B. The main ones they tend to talk about in exams are vitamin B1, known as thiamine, vitamin B2, known as riboflavin, vitamin B6, pyridoxine, and vitamin B12, our cyanocobalamin, which we mentioned earlier. So vitamin B1, thiamine. Thiamine is usually given to alcoholics those with Wernicke's encephalopathy, and the parental form of it is known as Prebinex. So vitamin B1 can be used in energy metabolism. So let's think about what foods give us energy. So when we wake up in the mornings, what do we need energy to start off our day? We need cereals. We need bread because we might have some toast. So that's where we can find vitamin B1. Vitamin B2, riboflavin, again, energy metabolism. So think milk, cereal. Vitamin B6, alpyridoxine. We've come across pyridoxine before in treatment of TB, because in treatment of TB we use isoniazid, but isoniazid therapy can lead to a deficiency of vitamin B6 or pyridoxine, so we give vitamin B6 to overcompensate that. Vitamin B6 is used in protein metabolism, so let's think of what foods give us protein, so fish, meat, and pyridoxine can also be used in metabolic disorders and in sideroblastic anemia. And we have vitamin B12, cyanocobalamin, which is used in red blood cell formation. Now, cyanocobalamin, it's usually one which vegans lack in, and that's because vitamin B12, the high amount, is found in meat, milk, and cheese. So usually if they ask a question that's related to veganism and which vitamin they're lacking in, it will be vitamin B12. And we have vitamin C, which we mentioned earlier, so we can find that in. It's also known as ascorbic acid. We know vitamin C, there's a high amount in orange juice, in citrus fruit, and it has antioxidant effects. And of course, if we're lacking vitamin C, then the patient can get scurvy. So one of the symptoms, as we mentioned, is gingival bleeding. Moving on to vitamin D, known as calciferol, and there's many different forms. We have ergocalciferol, alpha-calcidol, cholecalciferol, and it can be used for bones to regulate calcium metabolism, and a lack of vitamin D can cause rickets and osteomalacia. And what's important to remember with vitamin D is that too much of it can actually lead to hypercalcemia. So we know that vitamin D, we can get it from the sun. We can also get it from some food products as well, such as eggs and butter. Moving on to vitamin E, also known as tocopherol. There's actually little scientific evidence on benefits of vitamin E, but from what is known, it can be used as an antioxidant, and it's found in foods like whole grain cereals and vegetables. So vitamin K, also known as monaptone, that can help to produce blood clotting factors. So remember, with patients that are on warfarin, they need to limit how many green leafy vegetables they have. They're on a strict diet, and one of the restrictions is their green leafy vegetable intake. And that's because vitamin K, there's a high amount in green leafy vegetables, as well as in nuts and fruit. So also with vitamin K, it's, as we mentioned, it's a fat-soluble vitamin, but you can get a water-soluble version known as monadiol, and that's used in vitamin K deficiency in patients with malabsorption syndrome. And what's important with vitamin K, and one thing that they like to ask in exams, is that it's given to newborns to prevent hemorrhagic disease. So that's a very key use for vitamin K. Other vitamins include nicotinic acid, and that can be used to inhibit the synthesis of cholesterol and triglycerides. We also have biotin that can be used in protein and energy metabolism and can be found in kidneys, in liver. And there's beta-carotene, and beta-carotene gives carrots and peaches that orangey kind of colour, and that can be, the beneficial properties of that are antioxidants. We also have folate supplements or folic acid, and this can be found in kidneys, in liver, in vegetables, and it helps with red blood cell formation. With folic acid, it's important that a pregnant woman takes it during pregnancy to prevent neural tubule defects. So if a woman is at low risk of getting neural tubule defects, they should take folic acid before conception and up until the 12th week of pregnancy. So why might the offspring be at risk of neural tubule defects? Well, for example, it could be if the mother or the father has a family history of it, has diabetes, celiac disease, or if any of them are taking anti-epileptic medication. So that was the blood and nutrition section. So I hope you're understanding on anemias, electrolyte and fluids, so hypokalemia, hypercalcemia, vitamins. I hope your understanding is a bit better now. And if you found this video useful, why not give it a thumbs up, give it a like, subscribe, share with your other pharmacy buddies or whoever you think would be interested in this video, and join our Facebook page for all the latest updates. Until next time, good luck with your revision and happy revising.